Hi guys, I think we're live now. Yes, we are. So, hi everyone, welcome to today's session on psychiatry. My name is Olalade, and with me, I'll let Shantae introduce herself.
Hi everyone, I'm Shantae. I'm an F1 around Greater Manchester, so welcome.
So, welcome. I'm an F1 in the East Midlands region. So, today's session is on psychiatry. We hope you find it interesting and you find it useful. As always, feel free to ask any questions if anything isn't clear. And we'll get started. The QR code on the screen is for our research, which we're currently doing. So, we would really appreciate it if you could scan that code and just fill in the questionnaire, which is very, very short. I'll also put the link in the chat for anyone who isn't able to scan the QR code. Please fill in the link and share it with anyone else you think might be interested. Again, thank you guys for joining us, and we'll get started.
Okay, so a bit of a session outline. So we'll just be covering some of the common conditions that are sort of come under the psychiatry umbrella that we're expected to know for the UK MLA. So we'll be covering topics today from depression, anxiety, psychosis, bipolar, eating disorders, and mental health crisis. So sort of on the right to your screens, you can see, as per the UK MLA guideline, you've got your common psychiatric presentations that we should all be aware of, and then common conditions as well. So if we go to the next slide, please. So we'll start on question one. I think I'll let you guys just kind of read, answer in your head. There's also a poll in the chat. We'll give you about 60 seconds, and then we'll move on to the explanation. Okay, so if we go to the answer slide. So answer is D, so provides information and self-help strategies and monitoring. So according to NICE guidelines, so this lady presents with depression. Individuals who have less severe depression, the initial approach is to provide information with self-help strategies and then also monitor for the progress. So oftentimes when patients present with sort of low mood, sort of a lesser severity of depression, if you will. They're mainly looking for somebody to sort of speak to. So a lot of times it can be self-help strategies where they can maybe sort of maybe do like personalized self-help at home, or if they're wanting to speak to somebody, then you can potentially refer on. But often you will bring the patient back sort of in 4 to 6 weeks' time to check up how they're doing. If we go to the next slide as well, please. Thank you. So often with depression, the diagnosis is primarily clinical, based on sort of a comprehensive history and a symptom criteria. So in GP, there are sort of many different questionnaires that doctors can use, but a common one is PHQ-9. So you can either get the patient to fill that out themselves and then bring them in for a consultation, or you can fill it out with them whilst they're in sort of at the surgery then. And then in terms of depression criteria, so it's characterized as persistently low mood, loss of interest, loss of pleasure in activities, and then accompanied by at least 4 different additional symptoms. As we can see here, fatigue, sleep disturbances, and changes in appetite and feelings of worthlessness, and that can also come with plus or minus suicide ideation as well. So again, I mentioned the screening tool about PHQ-9, but there are a variety of ones as well. And if we move on. So in terms of management, so we, like I mentioned, we can have like follow-up appointments to determine sort of how the patient's doing, and then whether or not they need additional treatment, such as CBT or medications such as SSRIs or SNRIs. Lifestyle changes as well, so physical activity, changing the diet, trying to get a better sleep as well. Special considerations for quite severe depression, such as ECT. That's mainly for like treatment resistant depression as well. And then in extreme cases, potentially starting on lithium augmentation as well. Okay, so I think we can move on to the next question. So if you guys have a read, and I'll just pop the poll in now.
It's been 60 seconds. Do you want me to move on to the next slide?
Yes, please. Okay, so this patient is presenting with anxiety. So again, according to NICE, the first set of guidelines in order to treat patients with anxiety, such as generalized anxiety disorder, is to offer structured psychological therapy, such as CBT. Now, there are many forms of CBT, depending on sort of the subtype of anxiety. When you think of obsessive compulsive disorder, social anxiety as well, so you can pretty much tailor it to the individual and their circumstances. So if we go into the next slide as well, please. So again, you want to, doing the initial assessment, you want to try and determine what kind of anxiety that the patient might be presenting with. So you look to identify key symptoms such as excessive worrying, restlessness, fatigue, difficulty concentrating, irritability, and sleep disturbances. With anxiety and depression overall, there's quite a few sort of overlap as with symptoms, also with presentations as well. A lot of patients don't tend to present with just one, they might present with both. So it can be quite difficult with trying to determine the best way to treat those patients as well. But generally you go with, I suppose, what the feelings of the patient they're presenting more with, if that makes sense. So if they're presenting with more features and their main concern is anxiety, then you would offer the CBT route. If they were to come back after a period of time and you reassess them and they're still experiencing signs of depression, that's when you can start to think about introducing medication as well to assist with that. That's why that's coming under step 2. If we go to the next slide as well. So again, there's sort of special considerations for alternatives to medication and also to CBT as well. Again, it's a very tailored approach, and oftentimes, patients they can either refer themselves or get referral from their GP, depending on the type of CBT that they'd be they'd be most appropriate for. But generally, in terms of management, it's just monitor with regular assessments and supportive measures as well. I know a lot of times we say like the key words when it comes to like OSCEs and MCQs in terms of offering out leaflet advice. But leaflets tend to help patients a lot because a lot of the times during these consultations, patients aren't able to sort of retain the information. So if you're able to provide a leaflet that they're able to go away and read up about, it does tend to help as well. But a key thing is for management is making sure that there's appropriate crisis intervention that's put in place as well, that we can assist during these acute episodes. Next question, please. Okay. So we've got risperidone, which is a second line antipsychotic. So according to NICE again, NICE recommend offering second generation antipsychotics such as risperidone for treatment of schizophrenia. If we move on to the next slide, please. So in terms of diagnosing schizophrenia, again, it's a lot of psychological conditions. We're looking at like a clinical diagnosis and presentation. So looking for characteristics such as delusions, hallucinations, disorganized speech, negative symptoms, and a significant portion of time during a 1 month period as well that these symptoms are persisting for. And you also want to exclude other conditions, so ruling out other psychiatric disorders that could also explain further symptoms, so especially bipolar as well, which can have a similar presentation, especially if a patient is manic during that time, and looking at functional impairment as well. So if there's significant impairment in their social and sort of job environment. So again, first line treatment, we have second generation antipsychotics. If we move on. Thank you. Second line options, clozapine, that's especially important and kind of like a buzzword or a key fact to remember. They like to test you a lot on this. So treatment resistant schizophrenia. So again, with at least 2 different antipsychotic medications. And sometimes as well, you might find, especially more so in clinical practice, that the use of combining antipsychotics to sort of aid in the further treatment. Again, if somebody's even becoming resistant to clozapine, they might think to, combining 2 different psychotics to help with their symptom control. And again, the management is pretty similar to the other 2 conditions that we've looked at. So regular assessments, also looking at CBT therapy to help the patient understand their symptoms and understand the condition as well. And then also a big one for this is family intervention. So, getting family members involved and making sure that they're aware of the patient's condition and their understanding as well. And then community support as well. Okay, so if we go on to the next slide. Okay, so this one might have been a bit tricky, but a key thing about this question is being aware of common side effects of patients on clozapine. So clozapine can cause can induce neutropenia. So the absolute minimum of a neutropenia, a neutrophil count, we're looking at anything 1.4 times 10 to the power of 9 above, but this patient is below that threshold. So what we want to do, we want to temporarily hold clozapine and then repeat the FBC in a week's time. I can see there was a question, sorry, somebody selected B, so initiating another antipsychotic medication, which I mentioned previously, but I suppose the key point with this is that their neutrophils were lower than 1.4. So next slide, please. So a key thing with clozapine is regular monitoring of his FBCs. So again, I mentioned about neutropenia, but also the risk of agranulocytosis, so just a reduction in sort of blood cell production. And we should, if it's persistent, consider alternative antipsychotics. But again, it potentially could just be a one-off and the patient's fine, especially if the medication's working, because it can take so long to build up the levels in order to help the patient with their symptoms. You don't want to abruptly stop and change a patient's medication too soon. So again, with this question, it's just making sure that we're regularly taking the FBC levels about 4 to 6 weeks, and then initially repeat weekly until it returns within the safe level, and then you might repeat the FBC every 4 to 6 weeks. But yeah, next question, please. Okay, so the answer to question 5 is E. So this lady presents with postnatal psychosis. So it's considered a psychiatric emergency, and the patient needs, as we can see here, needs to be referred to a specialist perinatal or postnatal mental health service for immediate sort of intervention. So women who have just given birth, especially within those first two weeks, at an increased risk of developing postnatal psychosis. So if we move on, please. So sort of clinical features, so sudden onset of psychotic symptoms such as hallucinations, delusions, mood instability, and confusion, especially within those first 2 weeks. A lot of times women might find it difficult to bond with baby. They might have feelings of like a sudden, quite drastic sort of thoughts of wanting to cause harm to baby or harm to themselves or harm to the family. A lot of times if help's missed and if signs aren't picked up, and help is missed, a lot of times they can lead to like quite serious incidents of women harming themselves or baby as well. So a few risk factors to be aware of. So family history of bipolar disorder or schizophrenia, and especially if a woman has exhibited post or experienced postpartum psychosis in the past as well. It's sort of sometimes a bit difficult to distinguish if it is postpartum psychosis or if it is, potentially postpartum depression or delirium. So that's something to bear in mind, but that's kind of more specialists to be aware of. If you've got a woman who's just recently given birth and she's expressing sort of symptoms such as delusions, hallucinations, the first point of call that we should be aware of is urgent referral to psychiatry. Treatment is admission, and potentially initiate antipsychotic medications as well. And depending on how severe it is, also maybe consider the use of lithium. In severe cases, consider ECT therapy. And, if depending on how at risk the woman is to herself or others, consider sedation with benzodiazepines as well. So yeah, management, as we talked about, so just urgent admission into a specialised unit. Unfortunately, these units are very sparse around the country, so it can be quite difficult to get these women admitted, and oftentimes they might not be admitted into a woman and baby unit. It might have to be quite difficult and, make the difficult decision to separate baby from mother as well. But yeah, it's just sort of something to be aware of. And again, just monitoring as we discussed. Okay, so we'll move on to the second half of the questions where Ololade will take over.
So hi guys, again you have 60 seconds to read through the question and select your answers. 60 seconds, so I'll just give them a chance for someone to, if anyone else wants to answer. If not, we'll move on to the answer in the interest of time. So the answer to this question is referral to liaison psychiatry. Can anyone tell me what the diagnosis in this is? You can just pop it in the chat, say what the diagnosis is for this patient.
Do you want to tell us?
Yeah, okay, someone's put in the chat, good, so I didn't have to say it myself. So the diagnosis is bipolar, exactly. So he's presenting, and yeah, well done, guys, well done. So he's presenting with a current manic episode, but the key point to this question is the fact that this is very different to his struggle with his low mood last year. And so, you know, yes, these are all potential options that can be used at different points. Well, actually, not specific to bipolar, but yeah, you guys did well by selecting E, referral to liaison psychiatry, rather than, you know, initiating lithium, which I guess could have been the trick in this question. People think, oh, lithium is commonly used, but again, it's not necessarily the first line. So this diagram is from this book called Psychiatry, a Clinical Handbook, which is the main book that I used to study psych. And so I would highly recommend you finding that book. There's PDFs that you can find as well. So this is just a diagram from there, which just gives you the different categorizations. So bipolar, so it's a chronic episodic mood disorder characterized by at least one episode of mania or hypomania and a further episode of mania or depression. And so bipolar 1 involves periods of severe mood episodes from mania to depression, whereas 2 is a milder form of mood elevation, involving milder episodes of hypomania that alternate with periods of severe depression. And then you have rapid cycling, which has a worse prognosis, as you can see on the screen as well. So other things to note is the difference between hypomania, mania with psychosis and without psychosis. And so hypomania, there's preserved insight. So they're a bit more high mood, they're more elevated, euphoric, but actually they still have some element of insight into their character being out of place. Whereas when they are manic, either with or without psychosis, they tend to have loss of insight into their condition, and it's longer lasting in terms of, you know, the symptoms would have to be present for at least greater than 1 week. And this either with psychotic symptoms, in which case it would be mania with psychosis, versus without psychotic symptoms, which would just be mania without psychosis. And so in terms of, you know, the question, because I asked you guys what the diagnosis was, because in an OSCE, it's very easy for you to have a scenario where they present to you a patient with depression, and, you know, they come to you, because I had this in my OSCE actually for finals, where they literally just present with symptoms of low mood, they're sad, and they won't tell you that they've ever had a episode of mania unless you actually inquire about it. And that's one thing they do to catch you out, because the danger in that situation is they ask you how you would manage the patient, and then you go on to say options such as, you know, giving them an SSRI, which would actually be the worst thing you can do for someone with bipolar, because then you risk triggering the manic episode by giving them an SSRI. So that is something you always want to screen for. So whether you're in an OSCE setting or in real life, in any placement, if a patient presents with any symptoms of depression whatsoever, things you always want to do is a risk assessment. So no matter, you know, the circumstance, always make sure you clarify and ascertain, you know, any risks to self or others, and any risk of any thoughts of suicidal ideation, and any plans that they might have to implement this. Although it's a challenging conversation, it's always something, because I think for my OSCEs, if you didn't ask about risk, you automatically fill that station, because that is one thing you don't want to miss. So just always make sure that you screen for risk to self, to others, and the actual thoughts of suicidal ideation or any acts or plans they have to effectuate that, and always screen for mania in a depressed patient. So going back to investigations, again, from an extract from the book that I mentioned earlier. So there's different mood disorder questionnaires that you can go through, blood tests, you know, there's always organic causes of other things as well. So just make sure that you've ruled out other organic causes before putting it down to a psychiatric problem. And other things that you can do are on the screen, such as urine drug test and, you know, a CT head if indicated to rule out a space occupying lesion. So moving on to the next slide, there's always different frameworks for addressing different things, and biopsychosocial framework is always one that we were encouraged to use for a psychiatry station. So when you ask how you'd manage a patient, you say from a biological perspective, these are the options that we have, which the book also lays out really nicely. And from a psychological perspective, these are the methods in which we can implement to support this patient, and social aspects. And I guess what distinguishes everyone who reads the book and then just says biopsychosocial is actually having examples to back up things like that you say. So support groups, anyone can say support groups, but knowing the actual support groups that are available in the UK is something that's useful and actually makes you stand out from everyone else that just uses the word biopsychosocial without actually backing it up. And yeah, so on the other side of the screen is just specifics of things that can be used in the management of treatment, because usually first line they manage with an antipsychotic to actually stabilize them. Well, I guess lithium is the mood stabilizer, but to kind of help them overcome that acute phase of the manic episode, they're treated with antipsychotics. And then once they're established on that, then lithium is added in as long-term management to prevent relapse. So lithium is used in bipolar, but it's not, when a patient comes in with an acute manic episode, they're not just going to give them lithium. There are other methods to actually treat them, which is usually first line being an antipsychotic. So yeah, another thing to be aware of that can easily be asked in exams when it comes to bipolar is lithium monitoring. This also came up in my OSCEs. So, they will ask you what are the side effects, and for ours, they want you to distinguish between, what are the actual side effects versus signs of toxicity. So those were both questions that came up. What are the normal side effects versus what are also the signs of toxicity? And, you need to be aware of things like monitoring. So we already talked about clozapine monitoring earlier. Lithium monitoring, you need to also be aware of that. And, things like DI is something that could happen. So they can easily link a psych question to like a physical, mental health or endocrine problem like DI. And then, there's a patient who has bipolar, comes in, he's peeing loads. You see his blood test, the sodium is super high. So that's evidence that they're in diabetes insipidus. So just think about things from a broader perspective rather than just, this is a psych question. They can easily link psych, endocrine, and physical health things together. So yeah, we'll move on to the next question in the interest of time. Again, another 60 seconds. So I think there's a split between A and B, but the correct answer is B. I mean, A could potentially be a possibility, and I could see why you could think that. There's even a C as well, but C isn't the case for this patient. And so in terms of the patient, I think the diagnosis is hopefully obvious from the stem of the question, which is anorexia. So one of the common ECG findings with that is sinus bradycardia and prolonged QTC. And I put the QTC specifically just to remind us again of basic medical stuff like, what is classified as a prolonged QTC. So for females, that's QTC greater than 460. If it's a male patient, a QTC greater than 440. And so just remembering things like that. They are predisposed to different type of arrhythmias. So this is not by any means the only ECG finding that can be seen in a patient with anorexia, but this is commonly seen, and that's why it's the most likely finding. but they could have other forms of arrhythmia. Atrial fibrillation would be rare in a 17-year-old patient. Widespread ST depression is not a typical finding. Sinus tachy, unless they were particularly anxious at the time, which is very possible, and that the GP took that ECG. The anxiety from the whole situation can make them tachycardic. But in terms of the actual most likely finding for anorexia, it's prolonged QTC and sinus brady. So anorexia is characterized by fear of weight gain. They do have endocrine disturbances, but they don't have to have an endocrine disturbance for it to be anorexia. Usually emaciated with low body weight, BMI below the expected range, deliberate weight loss with decreased food intake, increased exercise, distorted body image, and all of this characteristics have to be present for at least 3 months. So if someone comes to you and they've just been feeling like this for a week, by all means, they may go on to develop anorexia, but you can't categorically diagnose it as anorexia at that point. And also, they have to have no recurrent episodes of binge eating, preoccupation with eating or craving to eat, because that's a different pathology, and that would be bulimia rather than anorexia. And again, it's always good to have, a structure for answering questions. So bedside bloods, imaging, special tests. So things that you can, do at the bedside is what the GP's done, ECG. Arrhythmias such as sinus brady and prolonged QT are common, as we talked about. Blood tests, they could be anemic. They use an ease if they're dehydrated. Can show raised urea and creatinine. Hypokalemia is common. Low phosphate magnesium chloride. Basically, almost everything can go wrong and go out of the parameters that you want. And so, just being aware of the common things. VBG wise, if you do a VBG in a setting where you can, they can have metabolic alkalosis from vomiting, metabolic acidosis from excessive laxative use. And imaging and special test wise, osteoporosis is a risk. So things like a DEXA scan, if you suspect it, can be done. And questionnaires such as the eating attitude test can also be used in that setting, such as the GP setting, to inquire more about the situation. So management wise, as I said, in psychiatry, the most important thing you need to do for every patient, regardless of what they present with, is a risk assessment. So, suicide isn't just for the depressed patient, and also people have comorbidities. Just because they have one condition doesn't mean that they can't have other things going on as well. So risk assess for suicide and medical complications. As I said, electrolyte abnormalities can occur. This can have significant cardiac complications as well. So we need to make sure that the patient is not compromised medically, and if they are, we need to address those problems. Treat medical issues. You can also give them SSRIs for comorbidities. And psychological treatments as well needs to last at least 6 months. Usually, there's different types of therapy. So there's cognitive analytic therapy. There's also CBT, which you've mentioned before, and family therapies can also be important in the management. By all means, this is not the only option there is, but these are common ones that are used with patients with anorexia. And as I say, when we talk about, biopsychosocial, and we mention support groups or leaflets, let's actually be specific and mention organizations that can help this patient. Because if you're in, a real setting where this is you as a medical student in a GP practice or a foundation doctor in a GP practice, you don't just want to be saying, oh yeah, support groups. So things like BEAT can help patients with anorexia nervosa in the UK. And in terms of the aim of treatment, if they're an inpatient, you want to aim between a weight gain of 0.5 to 1 kilogram per week. But in an outpatient setting, due to risk of things like refeeding syndrome, it's more controlled. So it's 0.5 kilograms per week. And I already mentioned refeeding syndrome, which is a risk and something that could be easily tested as well. And if they do have severe anorexia such that their BMI is less than 14, or they have severe electrolyte abnormalities and psychiatric or suicidal ideation, then they need to be admitted rather than outpatient management. This was just a nice little diagram that I saw for a summary of things to look out for in refeeding syndrome. So that might be helpful to you guys when you get the PDF later. So next question. Again, we've got split in the answers, and the correct answer is D, reversal of glucagon, because this is a patient who's taken a beta blocker overdose. And so this is also something very useful to know because it can come up under mental health or ED, because I remember us going over this in our ED placement as well in final year. So just knowing the common reversal agents or the antidotes to overdose substances is something that's useful to know. So on the screen, again, from the book that I mentioned earlier, but this is not an exhaustive list. So there are other things to be aware of as well. But yeah, paracetamol, opiates, benzos, warfarin, beta blockers. So, you know, you could easily get a situation where someone comes in, someone with chronic pain and depression, they're on amitriptyline for management of the neuropathic pain. And, you know, they ask you, what do you need to do to give to reverse that? And it will be sodium bicarb, for example. So just be aware of things like that. So hopefully that's useful for you guys. We'll move on to the next question. So it's been 60 seconds. I'll reveal the answer in section 3. So I think mental health sections is a very easily testable thing that can come up in OSCEs and written exams. So it's something to bear in mind. So we've got a split between section 3, section 136 and 135. So it's section 3 because this patient is being admitted for a treatment. So section 2 is for assessment, 3 is for treatment. And actually, I think I have a table. Yeah, there's a table here that kind of summarizes what the sections are. So this is, you know, if a patient has a mental health problem, we need to assess them and then consider treatment. That's a section 2. Section 3 is for treatment. This patient already has a diagnosis. We're aware that the problem is a relapse of their mental health condition and they need to be admitted for treatment. So that's why it's section 3. 135 and 136, which were in the other options from the question, are police sections. So 135 means they can go into someone's house and actually remove them to a place of safety, whereas 136 is police has the power to use that in a public setting. And then take them to a place of safety for assessment. And then 5.2 is a doctor's holding power. And then 5.4 is one that can be used by nurses. There's more sections to know, but I think these would be the main sections that I would expect you to know, and that would be commonly tested on in an exam setting. So I think this table from Intermed kind of summarizes that very well, and is something that I would highly recommend you just memorizing. Who can, use what, how long did they actually last for, because that's another thing they can test, and what did they cover. So have a look at this in your own time, because it is commonly tested. Next question, you have another 60 seconds. So there's a question saying, wouldn't the police need to remove him from his house first before using a section 2? So for him, he actually needed a section 3, if you remember, because it was a full assessment. But if you read the question, it says, however, the neighbors saw him come in via his CCTV and called the police, which led to the crisis team being contacted. So number one, he wasn't actually in the neighbor's house, first of all, and second of all, they contacted the crisis team, who came to assess the patient and arranged in a psychiatry inpatient admission. So the plan is already for him to be admitted as an inpatient, with the crisis team being called, but he lacks insight, evidently needs treatment, which he's refusing. So when it comes to a crisis team, the role of a crisis team is to facilitate treatment in a community setting. But in this case, this is a patient who has a high risk to himself and others, and lives alone, so they can't facilitate that treatment within the community setting. So the crisis team have come to the decision that he needs to go into an inpatient facility to be treated, and he's refusing that. So that's why section 3 needs to be applied in order to get him to have inpatient treatment. Does that make sense?
And it's also important to know, so police, if in any scenario where there's sort of serious concern to life or danger to them or themselves, they have the power to enter somebody's home, without the warrant. The section 135 basically allows the police to detain a person under questionable like mental health act, as in they're questioning somebody's state of mind, and then it allows them to remove them to a place of safety that potentially could either be ED or a holding area within the police station. So they don't need that section in order to enter somebody's house. They're able to do that as the powers of police. It's just sorry, I'm just answering a question. Is it the Ways and Means Act for police?
I'm not entirely sure what the Ways and Means Act is, but in terms of if your question is referring to whether or not the 136 is the Ways and Means Act, I don't think it's referred to as that, but that's open to correction. But yeah, so back to what Shantae was saying, it's more, when we're assessing a patient that we think has a mental health issue that needs to be addressed, these sections can be applied to take them into a place of safety. So I'm not entirely sure what the Ways and Means Act is, if that's in answer to your question, Adele, but these sections are kind of used or implemented by the police when there's a contention or when there's suspicion that there is a mental health impairment affecting someone's behavior and they need to be protected, in which case, as we said, they would either be taken to a place of safety, which can be within police custody or ED. So hopefully that makes sense. I'll give us about 30 more seconds for question 10 because we kind of went back to question 9. Before revealing the answer, just thinking more about it. So the sections that we've highlighted from the previous question is specific to the Mental Health Act. So things that you'll be tested on in the setting would be the Mental Health Act and the Mental Capacity Act. Just because someone has a mental health problem, the Mental Health Act cannot be used to treat a physical health problem. And so those are the things that they'll test you on. So whilst I don't know what the Ways and Means Act is, it's unlikely that they will test you on that, because what they care about is understanding the ethics and law in the context of a mental health and a physical health condition. So they would expect you to know the things that come under the parameters of the Mental Health Act, as well as the Mental Capacity Act. And usually those are quite clear and succinct points. So hopefully that makes sense. So answering this question, so the answer to this is A. So well done to people that picked A. So what this patient is presenting with is features of delirium tremens, and part of the history, we saw that this was a patient who last consumed alcohol 3 days ago before deciding to go cold turkey. Whilst I didn't give you specifics about his alcohol history, it's evident that this is a patient that has symptoms of severe alcohol withdrawal, and within the time frame that is listed in the question, delirium tremens is the most likely diagnosis. And so these are some of the features that we see which the patient experienced. Other things to be aware of when it comes to things like alcohol dependence is Wernicke's encephalopathy, as well as Korsakoff's. And so an acronym that some people use to remember that is COTRAC. So knowing which is which, because sometimes people say Wernicke-Korsakoff's as one thing, but it's not. They're not the same thing. And so I've already kind of explained what they are on the screen, and stated the features. So in terms of treatment of the acute alcohol withdrawal, then chlorodiazepam epoxide and thiamine replacement is the main thing, so Pabrinex. And in terms of longer term considerations in substance misuse psychiatry, the agents that can be used include disulfiram and naltrexone, as well as acamprosate. And one thing that actually came up, I think, in my first year exams was like motivational interviewing, and remembering the cycle of pre-contemplation, contemplation, and going through the whole cycle of seeing where patients are at, because you kind of need to figure out where they're at and then see what interventions will be best suited to them in order to effect the change that they need. CBT is also a useful tool in this setting. And then in terms of we talk about the biological agents, psychological stuff like motivational interviewing and CBT, and social things like support groups. Alcohol Anonymous is one popular one, but there are other ones out there, and there's some local to your trusts or local to your environment as well. So it's good to also know, everyone will mention Alcohol Anonymous AA, but actually which services are local to your area. It's nice to have that, because that gives you, that shows you actually understand. And also in that situation, if you're ever seeing someone in GP land or in any other clinical setting, you're able to then actually give them proper support rather than just saying the basics that everyone knows. And so there's different questionnaires that can be used in this setting as well. A CAGE questionnaire is something that's commonly used because it just highlights, it's easy to remember the acronym CAGE. So, have you ever thought you should cut down on your drinking? If they don't see a problem in the, fact that they're drinking excessively, that's already a red flag. Have people annoyed you by criticizing or annoying your drinking? To the A stands for being annoyed. Guilty is the next thing. And have they ever had a drink first thing in the morning as an eye-opener? So, going through that, if they score 0 or 1, then that's not as much as a problem. Whereas if they score 2 or above, then that's, high suspicion for alcohol dependence. And that's not to say someone who, they could easily lie to you and say, no to everything. That doesn't mean they're not dependent on alcohol. So these are just tools to guide our assessment. They're by no means a diagnostic tool. So it's just something to help you screen as well. So there's different questionnaires. There's the Audit C as well. There's a SAD Q, I believe. So just know whichever ones that are commonly used to screen for things like this. So I think that's the main one, and that's it from me, really. So thank you guys for joining us. We hope to see you in our next session. If you do have any questions, please put it in the chat, and I will be happy to answer them. I'll hand over to Shantae if she has anything else to share with you guys.
Yeah, sorry, just a few things before people go. Just something to be aware of, more so for when you start clinical practice. So IV Propranex, they're kind of phasing it out. It's something to do with like the license is expired, so it'll be IV thiamine. I don't know if we've got any like final year. So when you start in a few, like 2 months' time, it'll be IV thiamine. For those who are still yet to sit the MLA, it might not have updated yet. So just don't be surprised if you see IV Propranex or thiamine, basically the same thing anyway. And then also as well, just to be aware about potential recent changes to the 135 and the 136. Literally this week, the government have announced that they will potentially be changing the powers of those who can implement the sections to an authorized person, and that can include doctors, mental health nurses, potentially some advanced practice psychiatric nurses as well. It won't change the MLA, but it's just to be aware of changing guidelines and what that means in terms of extra pressure on the NHS. If police officers aren't going to be enforcing section 136 or 135 anymore, they potentially could, move the patient to a safe space, i.e. ED, and then that puts additional pressures because they can then say, well, you have the power to enforce this section. Yeah, it's just to be aware of that potentially could be a change in the next coming months also.
Thanks for that. And again, thank you guys for joining us. Yeah, I've put the feedback link in the chat so you guys should be able to see that. So please fill in the feedback. That's very helpful for us, as well as the research questionnaire that I put in the chat earlier. I think I'll put it in again. We're not trying to spam you guys with stuff to fill in. They're very short, so hopefully you guys have some time to fill that in. And thanks again for joining. We'll stick around for the next 1 or 2 minutes to see if you have any further questions. Otherwise, enjoy your evening.